Hello, I am Dr. Sandeep Hatwar and welcome to my channel. If you haven't subscribed to my channel yet, please do subscribe it and hit the bell icon. I am here to discuss today the Moran-Baker cyst. On the basis of this model, we will see the complete anatomy of the knee joint and hear how the Moran-Baker cyst appears, what is the etiology, and the various anatomical details of the knee joint. For this, let us have a closer look at the knee joint. So this is a right knee joint and that is the medial side which is marked. The one which is flickering now is the medial meniscus, and now that is the lateral meniscus. This is the posterior cruciate ligament, and the one which is flickering is now the anterior cruciate ligament. Now for a better look at the knee joint spaces, this would be the better view. This is as what is seen from outside. The skin is now removed and now you get only the skeletal muscles. Let us one by one see the skeletal muscles. The one which is flickering is a semitendinosus, that is on the medial aspect. Below the semitendinosus there is semimembranosus, and the blue dot that is seen there is a semimembranosus bursa. The muscle which is now appearing and disappearing are the two heads of gastrocnemius, the medial head and the lateral head. This is a popliteus muscle which is flickering. Let us remove that also. And now this is the capsule of the knee joint. The white structure which is overlying the capsule of the knee joint, which is now disappearing, is the oblique popliteal ligament. Now this is the point where the capsule of the knee joint is weakest, and from here there is a herniation, and that thing which has been highlighted is a semimembranosus bursa. So these two are the important structures for the formation of Baker's cyst. This is the capsule of the knee joint. Now it is disappeared. This is a plantaris muscle, and this blue structure is arcuate popliteal ligament. So that's all about the anatomy of the knee joint. Now coming to the etiology. Now in children, mostly the Baker's cyst arises from the semimembranosus bursa, and it rarely communicates with the knee joint, and majority of the cases it is related to the trauma. Because it is not communicating with the capsule of the knee joint or maybe with the knee joint cavity, so the excision is the only treatment. In adults, mostly it is due to the excess formation of the synovial fluid. Whatever may be the cause, that may be trauma to the medial or the lateral meniscus or the cruciate ligament, the rheumatoid arthritis, osteoarthritis, gout, all this condition leads to the excess formation of the synovial fluid because of the irritation. Because of this excess synovial fluid formation, there is increased pressure inside the knee joint, and that will push the synovial membrane from the weak portion of the knee joint capsule, which is in the posterior part, and this will cause herniation. Sometimes the bursitis of the semimembranosus bursa that communicates with the cavity of the knee joint, and then it results in the formation of the Baker's cyst. Whatever may be the etiology, I have my own mnemonic, that is the congenital tumor, trauma and infection. I will try to fit in all these causes here, except that tumor is not here, so just erase it. The rest try to fit in. Lastly, ultrasound is the diagnostic, and also we need to do a Doppler when in suspected cases, just to rule out the popliteal aneurysms. So this is all about the Baker's cyst. To see the surgery on Moran-Baker cyst or a popliteal cyst, please subscribe to my channel and get the notifications. Thank you.